Okay, welcome everybody. It's the next Tuesday seminar. My name is Alena Skalova, head and neck pathologist, and I have three very easy cases for you. The first one is a little bit pitfall. This was the tumor of a 15-year-old child, male child, boy. And that this patient underwent this is a consult case from Italy, and the boy had a biopsy, a probatory excision from the tumor, which is located in palate, diagnosed somewhere else in other hospital as adenoid cystic carcinoma, and then sent to other hospital, and from then as a consult case. So you can see that the tumor is covered by relatively intact or completely intact squamous keratinizing epithelium of the mucosal surface. You can see here that there is this small minor salivary gland. The tumor in this scanning magnification is pretty cellular, yes. Quite organoid, and if we use higher magnification, this is like this, we can start to appreciate the cytology of the cells and maybe even the structure. So what you can see is a still solid alveolar growth pattern and some extracellular matrix deposits. Hyalinized extracellular matrix deposits. Still high magnification. I try my best. Now it looks better. I hope that you can appreciate that the cells are relatively regular, with a roundish nuclei, eosinophilic cytoplasm, and again I will start to show you. I'll try to show you deposits of hyalinized matrix. That was probably the reason why diagnosis from probatory excision was adenoid cystic, but it's a 15-year-old boy, so it would be quite unusual. So what it is, it's a tumor which is not encapsulated, but it does not matter. It's correct. Let me show again. Scanning magnification, again the surface, a lot of hyalinized tissue, and that is something which should not be seen in adenoid cystic carcinoma, which is keratinizing squamous epithelium, as you can see here. That's a focus of squamous epithelium, and there were others as well. And so that was the first finding, which does not fit very well with adenoid cystic carcinoma. And then finally we have something which is beautiful, and that's finding, I marked it somehow by dots, and you can follow with me. I hope that it will be possible to show you quite well with higher magnification, and that's the presence of this structure, which is we described with Professor Michal many years ago. I would not tell you how many years, as a collagenous crystalloids, and it's a typical product of myoepithelial cells. Mostly at the beginning, or in majority of cases, in benign tumors, but it has been published also in single cases of myoepithelial carcinomas and somewhere else. So collagenous crystalloids and collagenous spherules, that's the finding which is typically seen in myoepithelial tumors, cellular pleomorphic adenoma or myoepithelial tumor, benign myoepithelioma. And then around these structures you can see cells which are called hyalinized plasmacytoid or hyaline cells, which are modified myoepithelial cells. So finally, the diagnosis is benign, and that's a big difference from adenoid cystic carcinoma. The pitfall with the pleomorphic adenomas and myoepitheliomas in oral cavity arising from minor salivary glands is the fact that they are not encapsulated and may really mimic invasive growth pattern as this case actually did. So that's the first case which I wanted to share with you. Final diagnosis, benign myoepithelioma or cellular pleomorphic adenoma of minor salivary gland. Second case is also quite easy. 53-year-old woman who had been diagnosed for, or she had, 53-year-old woman, she had a tumor in buccal mucosa. Try to find it. And it was sent in consultation. As you can see, the tumor is organoid, composed of nodules and alveoli made of clear cells. There is a lining mucosal surface here. Here I made a note, dots, to show you something which probably was the reason of incorrect diagnosis. There is a ectopic sebaceous glands in the mucosa of oral cavity, but that's possible. However, the tumor is not sebaceous adenoma as was expected by a referring pathologist. The diagnosis was possible sebaceous adenoma, which is not correct. And looking just at the places composed of clear, very good, it's there, that's correct. So this is a typical finding. You see that there are cells with clear cytoplasm, but also cells with eosinophilic cytoplasm. So this area is confusing, let's say, but we also have other areas in this tumor, and this is what we need for correct diagnosis, and that's more glandular structures seen here, for example. And if we start to think about correct diagnosis, which has already been mentioned here, you start to see cells which are not foamy histiocytes, but they are actually mucocytes. So final diagnosis was mucoepidermoid carcinoma, clear cell variant, and diagnosis has been confirmed by finding of appropriate fusion, which in this case was CRTC1, yes, CRTC1 mammal 2, and this diagnosis is quite nice, I believe. And last case was my own case, or routine biopsy. This was 78-year-old female patient who was operated for tumor in the oral cavity, localized or site at the interface between soft and hard palate. And what you can see here with scanning magnification is a ulcerated surface. You can see that there is squamous epithelium, a lot of it, with pseudoepitheliomatous hyperplasia. Maybe this is quite complicated picture, but there is this large ulceration, and what is below looks really like malignant tumor, maybe with invasion, no capsule, nothing like that. But well, we are in the oral cavity, which is always difficult, and you start to see also other features of this tumor, which is biphasic, some myxoid stroma, and you may also start to think of correct diagnosis looking at the cells with high magnification. And again, what is this? This is plasmacytoid myoepithelial cells, another example of the pitfall. This is a pleomorphic adenoma, and I'll show you immunome, which is positive for plaque-1, but we have to find it first. So here we are, somehow. And you can see that the cells are quite nicely positive for plaque-1. This case was submitted also for molecular testing, and we have found CTN and B1 plaque-1 fusion, which is one of possible fusions for benign pleomorphic adenoma. The good feature is this what I stopped here, squamous keratinizing foci. This is metaplastic benign pleomorphic adenoma of the oral cavity. And all these cases show that diagnosis of even very common pleomorphic adenoma may be difficult in oral cavity, particularly because of lack of capsule and because of possible ulceration and metaplastic changes. So that's all from my side for today. Who's the next?
Good afternoon, everybody. It's Michael Jr. here. First case, it's a pretty common soft tissue tumor. This was a 38-year-old male with a tumor on his lower leg, somewhere on the thigh. And we had just these little fragments where the tumor tissue is found just here. So some quite monotonous void cells, myxoid stroma, no pleomorphism. Then you have these quite prominent thin-walled vessels, arborizing vasculature, and very helpful findings are here. These vacuolized cells, which are basically lipoblasts. You can see the nuclei here. So these are primitive adipocytes, even better in these areas. So a relatively young patient, lower extremity thigh with this morphology, so some lipomatous differentiation, this prominent arborizing thin-walled vasculature, monotonous proliferation of ovoid cells. This together gives number one differential diagnosis. Anybody has a suggestion what this could be? Excellent, yeah. This is very suspicious for, or almost histologically diagnostic for myxoid liposarcoma. This case was actually very easy because it was already a recurrence of a tumor that was resected, so we knew the patient has this diagnosis before. And just to confirm, it's not needed really, but since we have the antibody, so myxoid liposarcomas have typically fusions of EWSR1 or FUS with DDIT3 gene, and this causes the overexpression of DDIT3 protein in the tumor tissue. So you can use DDIT3 antibody, which should show nuclear expression. This reaction isn't perfect, but you can still see some positive nuclei in the tumor tissue, so this confirms again diagnosis of myxoid liposarcoma, low grade. There is a high grade variant which used to be called round cell liposarcoma in the past, but there you need just a very cellular round cell proliferation without the adipocytic differentiation. So next case was a 8-year-old male, tumor on the thigh again. I'll start with scanning magnification. So a little bit, let's say, polypoid or exophytic lesion in the dermis, covered by unremarkable squamous epithelium. So it's not encapsulated, but it's quite well circumscribed, and it's dermal based, purely dermal based. There's nothing in the epidermis. When you look on higher power, cells are kind of epithelioid, quite large. Eosinophilic cytoplasm. The high power isn't that great here, but still you can appreciate that again the cells are monotonous pretty much. There are no mitoses or very few mitoses, no major atypia. So although it's very cellular, it looks a little bit worrisome on low power. On higher power, the cytology isn't that aggressively looking. Again, with this constellation of features, lower extremity, exophytic lesion based in the dermis, very well circumscribed, relatively small. There is one, there are a few differential diagnoses, but there is one number one differential. Any suggestions? It's S100 negative, SOX10 negative, definitely. Dermatofibroma, exactly, which one?
Cellular.
Yes, it's cellular, but it's also ALK positive.
Epithelioid.
Yes, so this is epithelioid fibrous histiocytoma. So it's a molecularly distinct variant of fibrous histiocytoma or dermatofibroma. So again, these are very often sent for consultation. They are pretty common actually, and it's just because people don't think about them. All you need is ALK immunostaining and exclude melanocytic lesion by doing SOX10 as 100. Because of course it mimics melanocytic lesions. It's completely benign. Okay, this one was tough. This is a consultation from Brazil. It was an elderly lady with a huge fungating tumor on her face, like 5 centimeters in diameter. It was actually, there was a worm inside of it. Worm eating on the tumor. It was horrible picture. So a long-standing lesion in the skin. Already from this magnification, you may expect something aggressive because very cellular, very dark. The epidermis, I will not be going around, but there was nothing in the epidermis. But the tumor is kind of abutting the epidermis and looks aggressive, very cellular, quite atypical, still relatively monotonous, but the nuclei are hyperchromatic. There's innumerable mitoses, a lot of atypical mitoses. So you can definitely think number one here should be to exclude melanoma, but all melanoma markers were negative. Can still be, of course, the or undifferentiated melanoma, but that's basically already a molecular diagnosis in this case if you don't have any markers positive. They also did like a broad spectrum of other markers. There was some CD99 membranous expression and WT1 nuclear expression. So these two markers tend to be positive, like both of them tend to be positive in chick sarcomas, which chick sarcomas are basically the second most common round cell sarcomas after Ewing sarcoma. And this would actually fit very well for chick DUX4 sarcoma or chick sarcoma. So monotonous round cell, aggressive looking neoplasm. So when they sent it, I was planning just to do DUX4 to confirm my impression. So DUX4 is again antibody detecting the overexpressed DUX4 protein, which is produced by the fusion. We recently had a study with Cleveland Clinic where we tested over 40 cases of chick DUX4 sarcoma, and all cases were positive with this antibody, usually diffusely positive. So when the immuno came back negative, I thought it's just not the diagnosis, it's something else. We did molecular, and it came back with ChIK-DAX4 fusion. So this is the first case which is negative for this antibody, at least the first case I know of. So this is a ChIK-DAX4 sarcoma. It's pretty rare, or very, very rare in general, and even more rare in the skin. It's typically a tumor of deep soft tissues, but here it's actually in the skin. Second most common round cell sarcoma. Yeah? Very, very aggressive. It's more aggressive than Ewing, and it doesn't respond to the Ewing sarcoma chemotherapy. Next case was a 19-year-old female with a tumor in her clivus, at the base of the brain next to the brainstem, and this was the morphology, fragments of tissue. In some areas where it was easier to appreciate, you can see again very cellular, monotonous neoplasm. It's round ovoid cells. There's a lot of vessels, but they are not very prominent. They are small vessels, small capillaries. And then there is another appearance to it, where you basically have in the background the same cells as we saw at the start, but there in these other areas you have a lot of these calcifications, basically very diffuse, very fine calcifications in between the tumor cells. And this constellation of features, this kind of cellular monotonous round cell tumor, a little bit reminiscent of solitary fibrous tumor, or what formerly was called hemangioperitocytoma. Now this is part of solitary fibrous tumor. So this is one component, and then these so-called grungy calcifications, very fine calcifications in between the tumor cells, made me suspicious of phosphaturic mesenchymal tumor. So there is no magic immunohistochemistry for phosphaturic mesenchymal tumor, but these tumors tend to be positive with SADB2. SADB2 is a marker of osteogenic differentiation. So there was some SADB2 expression. This marker is quite non-specific, so it doesn't mean that much, and it's not very diffuse in this case, but it's there. It's unquestionably positive in some cells. Another marker that tends to be positive in phosphaturic mesenchymal tumors is ERG, which is typically used as a vascular marker, but it's also a marker of chondrogenic differentiation, and it was beautifully positive in the nuclei of the tumor cells. So ERG is positive, and another marker that was found to be positive in phosphaturic mesenchymal tumors is somatostatin receptor 2, which is here as well. I'm looking for some area without the calcifications. So the cells are, again, unquestionably positive. So phosphaturic mesenchymal tumors typically present with phosphaturia, osteomalacia, but there are some 10% of cases which don't have that, or maybe don't have that yet. This patient didn't have any abnormalities like that. Also, about half to 2/3 of phosphaturic mesenchymal tumors have FN1 fusions. This case didn't have the fusion detectable, but still the morphology is typical of that. I think the location is very, very common. Head and neck is a good location for phosphaturic mesenchymal tumors. It's a very rare tumor we see here, maybe one case a year at most. So something more common, 69-year-old male, tumor on his back. So skin excision, deep excision or small resection maybe, you can say. So epidermis was quite unremarkable. There was nothing in it, at least nothing I could find. But there's of course, quite a high-grade looking tumor right next to the epidermis. And the tumor extends from the dermis all the way down to subcutis. So it's infiltratively growing. It has perinaurial invasion in some areas. And when you look here, it looks kind of epithelioid, or even you can think of rhabdoid morphology, nested, prominent nucleoli. So this would be definitely in the skin of an elderly patient. Again, number one would be melanoma here. So this is 100 done, and it was positive if I find the tumor actually. Okay, this slide is not very good, so I'll go to, this is SOX10. SOX10 diffusely positive in all the tumor cells. You can see how it extends all the way in the subcutis. Although in the H&E you can really see the cells very well. They are there. This 100 was the same. I've probably not the right marker. The right slide. So tyrosinase was negative. HMB45 was negative. PRAME was positive in the tumor cells. PRAME is a very non-specific marker for melanoma, but when it's not there, you can not, I'm not saying forget melanoma, but it makes melanoma very unlikely. So if PRAME is positive, it still makes it possible. And because we didn't have the other melanocytic markers, BRAF and RAS immunohistochemistry was negative. BRAF and RAS, of course, stains tumors which are RAS mutated or BRAF mutated, which are the two most common mutations in melanoma. It was negative, so we did molecular testing. There was NF1 mutation, which is the third most common mutation in melanoma, and there was also UV signature. So you can from the genome of the tumor, you can abstract. It's called tumor mutational signatures, and the tumors which are caused by UV chronic UV damage should have the UV signature. So this case had it, and so it was called melanoma. I don't know if to call it desmoplastic melanoma or normal melanoma. But the patient is, if he has an aggressive clinical course, he might be immunotherapy might be a good choice for him. So next case was an 8-year-old boy. It was a cystic lesion on his thigh. Unfortunately, we had just this small sample, so it's not very illustrative case. Still, we see some evidence of, or some pigmentation. It looks like brown pigment, so you can think of melanin or hemosiderin. You can see a lot of blood here, so it's more likely to be hemosiderin. Also, the lesion was negative for all melanocytic markers, I can tell you right away, so this is most likely hemosiderin, and the cystic appearance to it were most likely, given the morphology of these large blood-filled spaces. Then you have a lot of inflammatory cells in the tumor, and then the tumor cells themselves. I'll try to find the best. You see the lymphoid tissue here. So the lymphoid tissue is typically at the periphery, but since we see fragments here, it's hard to say where they are located. And here we see the tumor cells. And if you look closely, this tumor typically has, this is a angiomatoid fibrous histiocytoma. This tumor is, at least for me, very characteristic cytology. It's so-called histiocytoid appearance of the cells. And when you look at the nuclei, they have kind of like a pale staining chromatin. It's always present in these tumors, pale staining chromatin. So angiomatoid fibrous histiocytoma. These tumors, again, there's no magic immuno for it, but there is again combination of stains that tend to be positive. One of them is desmin, which there was, I think, yeah, there was some expression. It's usually focal to patchy, so here we have some focal expression. There is also typically EMA expression. There was some EMA as well. Not sure, maybe this is the pigment only. And a lot of cases tend to be ALK positive. ALK was negative here. But what is useful diagnostically is that all cases have EWSR1 fusions with most commonly ATF1 fusion partner. So I did EWSR1 fish, only just the EWSR1 fish. It was positive, which together with the morphology confirms the diagnosis of angiomatoid fibrous histiocytoma. Despite the name, these tumors have nothing in common with normal fibrous histiocytomas. They are different genetically, and they are considered low-grade sarcomas because they may metastasize to regional lymph nodes, or occasionally, very like 1-2% of cases may give rise to distant metastasis, but still almost all patients survive. Okay, this was 7-year-old boy, and this was on his in the chest wall, in the thorax, in the subcutis. Fragments of tissue, hard to find where is the surface, where not, but so this seems to be going to the subcutis. Where is the mouse? Here. So this seems to be going to the subcutis, this seems to be the dermis, and somewhere here might be epidermis if we had it, but we don't. But still, it's deep. It's deep in the dermis and in the subcutis. And the morphology, it's not very characteristic. It's bland spindle cell lesion, moderate to low cellularity, a little bit storiform arrangement. But the cells do not look like dermatofibrosarcoma protuberans very much. They are not that nicely spindled, monotonous. These are spindle to stellate cells. Some are ovoid, some are more spindled, so kind of more cytological variability than you see in dermatofibrosarcoma protuberans. So here you can think of dermatofibromorph fibrous histiocytoma, normal fibrous histiocytoma, which would be definitely number one differential for me, or maybe perineurioma. So we did some staining. CD34, it's always a good marker to start with. So the tumor is diffusely positive for CD34, which kind of made me move away from cellular fibrous histiocytoma. Then I did EMA. I don't recall how it's stained. I think there was some focal staining or something that looked like a staining. Not sure. Nothing really prominent. Then another perineurial marker is claudin 1. Which you can see there's some faint color. It looks like it's maybe staining, but I'm not sure. The immuno is sometimes hard to read, and this is so weak. But you can consider it positive or negative based on the overall impression, basically. And another very sensitive but the least specific perineurial marker is GLUD1, which, if it's perineurial lesion, it tends to be strongly positive. Here, some areas are kind of strongly positive, but most are weakly positive. So I wasn't sure what it is, basically. I didn't think it's dermatofibrosarcoma protuberans. Morphology looked best for me for dermatofibroma, but CD34 is positive. Now, CD34 should be always negative in dermatofibromas or fibrous histiocytomas, but then there are these studies about deep fibrous histiocytomas, which, when they are in subcutis, they are positive for CD34 in like 40% of cases. I just wasn't sure. And also in the kids, you have these kinase fusion positive tumors with NTRK, RET, MET fusions that can be over time become aggressive. So I just did sequencing to confirm or find out what it is. and there was PRK-CD fusion, which is the most common fusion in normal dermatofibromas. So this is just a deep fibrous histiocytoma. I'm not sure if I would do sequencing if this was in a 60-year-old. I'll probably call it benign looking or low-grade spindle cell tumor, whatever. But since it was a small child, I spent those $1,000 for sequencing. Okay, and last case, this was just a routine case from the faculty hospital, older male, synovium from his knee, and the patient has osteoarthritis. So you can see the synovial fronds here, covered by synovium, maybe mildly hyperplastic here. What is important here? There's a lot of fat tissue in the synovial fronds, which there's so much of it. This is clearly abnormal, and it's diffusely present. Almost in every slide, you have this fat tissue in the synovium, and this is called either synovial lipoma or more commonly lipoma arborescens, because it creates this arborizing synovium, which is enlarged, hyperplastic. And typically in patients with osteoarthritis, and very often it's bilateral. Nobody knows why. So sometimes it's hard to, when you have a synovial front when there are some fat cells, it's hard to say what's enough for this diagnosis and what's not. So there is no cutoff, of course. It's impossible to make a cutoff for that, but this is so much that this is clearly abnormal. So lipoma arborescens. Often you have this myxoid material there as well. It's probably just reactive change.
You should have a radiology correlation to that to call it lipoma, synovial lipoma or synovial lipomatosis.
That helps if you have radiology. And it's a luxury for us.
Everyone, Marian Schwedler here. I've got a couple of easy regular cases. This is FNAB specimen from a submandibular mass, so it's somewhere on the head and neck, and it's let's say still quite young male patient. And there's mass lesion next to submandibular gland, and you can see there's a lot of blood there and some cells there. Yeah, and eventually after searching you'll be able to find this. I believe this is pretty much easy case, okay? So any guess or a diagnosis? It looks epithelial and it looks squamous, okay? So the next step we have to do, because it looks like keratinizing atypical looking squamous epithelium, we should do P16 staining. And these cells were diffusely and strongly P16 positive, but when thinking about metastatic oropharyngeal squamous cell carcinoma, it looks keratinized, and it's P16 positive, but it's metastatic setting, so we have to perform molecular genetics, and it came back as HPV positive. So suggested diagnosis was a metastasis from oropharyngeal squamous cell carcinoma. So pretty fast and easy. Taky dobrý, tam daj ten zápisník, dej Mišovi, prosím tě. To musím ještě. Okay. The next case, although I'm not head and neck pathology, is again head and neck pathology, and this is a core needle biopsy from parotid gland. And you can clearly see its tumor there. And it shows this very nice organoid pattern, some basaloid cells, maybe even with some luminal differentiation, so probably biphasic tumor. And so, any guesses for the diagnosis?
Where is it from again?
Parotid gland.
Oh, adenoid system.
Okay, I made that mistake and I performed MYB, immunohistochemistry. This is MYB, MIP, staining, which gave something positive in the nuclei, but word of caution, MYB staining is quite non-specific, okay? So just this, I don't know how to call it, it's focally positive. This does not confirm a diagnosis of adenoid cystic carcinoma. And still, the neoplasm looks quite blunt to me, to be adenoid cystic carcinoma. So we have to perform some other markers. And of course, the lesion was positive for SOX10 with some CK7 positivity in the luminal cells, and some P63 was positive. And importantly, this is beta-catenin staining. So it looks a little bit overstained, but you can see that it's clearly membranous in the luminal and some cytoplasmic as well as nuclear positivity in abluminal cells, but there's even better marker called LEF1. And it's nuclear marker and much easier to interpret the staining, and it will give you this positivity in these abluminal cells. So now the diagnosis is basal cell adenoma. So basal cell adenomas of salivary glands have beta-catenin mutations, and we have proxy markers for that. That is immunohistochemistry for beta-catenin protein and LEF1, which is much better compared to beta-catenin. The next case is a soft tissue lesion in abdominal wall. It's let's say middle-aged female patient, and the sex is quite important because these lesions are more common in females compared to males. And we can see this fatty tissue with this quite well circumscribed but still infiltrative, okay, lesion. So there are adipocytes within the lesion, and we've got these short tongues of the lesion going into the fat. This is very basic pathology, and this is quite typical image. These long, sweeping fascicles of cytologically very blunt spindle cells, and the prime differential diagnosis is fibromatosis or desmoid tumor. And again, it's not really necessary, but it's nice to have beta-catenin staining, and as you can see, it gave nice nuclear and some cytoplasmic staining, which is abnormal. And again, I performed immunochemistry just to like compare performance of antibodies. This is again LEF1 antibody, and it's not that nice like in previous case, but there is nuclear immunoexpression. So the final diagnosis is there's my tumor or fibromatosis. Okay, I've got, I believe, only brain tumors right now. First one came as a consult case. This is posterior fossa, so in the cerebellum. It's a young female patient. She's now 35 years old, but she experiences like recurrences of brain tumor for a couple of years right now. So many times excised, and there were many diagnoses done before at other departments. You can see this. Including glioblastoma and pilocytic astrocytoma, which are completely different entities. And you can see this infiltration of this cerebellar folia here. So even Lermite-Duclos disease was one of diagnostic consideration which I consider to be like crazy differential diagnosis because it does not look like that. And yeah, maybe here are some atypical glial cells. It's really nondescript in my eyes. There's one another H&E. Yeah, this looked mostly normal. So I did perform methylation profiling as well as NGS, and it came back as a high-grade astrocytoma with piloid features, and also showed mutations in, I believe, BRAF gene and ATRX, which is quite consistent with an entity. So this is one of the two entities in current WHO classifications which you are not able to do the diagnosis without methylation profiling. The tumor shows quite bad prognosis, which is only a little bit better compared to glioblastoma. And morphology, although it should show some piloid features, sometimes it doesn't. Now we've got another case. In fact, these cases came maybe a week or two apart. Again, it's quite young person, female, and it was a tumor of the pineal gland region, and it was sent with a diagnosis of some kind of weird pineal gland tumor, which I believe is not, just by looking at H&E. And again, it looks rather nondescript, but it looks glial, and it showed OLIC2 staining, GFAP staining, and surprisingly there was quite of synaptophysin staining, so I didn't know what it is just based on H&E and immunohistochemistry. And again, we have performed methylation profiling, and the diagnosis is high-grade glioma with piloid features, which are not present at all microscopically. So this is still quite new entity, and we still didn't have chance to appreciate the whole morphological spectrum of the tumor type. So it's quite important to have methylation profiling in tumors like this. So completely different picture. this is nice case. Again, it comes from the brain. It was tumor in supratentorial location, so in brain hemisphere. And when I looked at the microscope, I was a little bit surprised. I was not expecting something like this. Probably the preferred diagnosis was glioblastoma or something like that, but you can see this quite monotonous spindle cell malignant proliferation with some mitotic activity. And at first I thought that it doesn't look like any primary brain tumor. Okay.
Where is it exactly located again?
Sorry?
Where is it located again?
It's supratentorial brain tumor. And it looks almost MPNST.
Looks like MPNST, yeah.
Okay. This was my first thought. MPNST. We have examples of MPNST occurring as CNS tumors, but these are very, very rare. And the reason is obvious. We don't have like nerves in the CNS. I mean, within the brain or parenchyma or spinal cord parenchyma. So it could be MPNST, but this is S100 protein staining, and Soxten is similarly diffusely and strongly positive. So this is not classical MPNST. This diffuse staining almost rules out MPNST. Okay. So with S100 and Soxten positivity, I performed other melanoma markers, and all came back positive. So this is metastatic spindle cell melanoma, and based on morphology, I suggested that they should look into patients' eyes. Yeah, because this is quite typical morphology for uveal malignant melanoma. Of course, you may have cutaneous melanoma or mucosal melanoma with morphology like that, but I'm almost sure that it comes from uveal. Although I don't know the follow-up of the patient. Maybe I will skip this one. This is better. This is another brain biopsy from, let's say, still young adult male, and it's somewhere in the midline structures, thalamic tumor or near the thalamus, and you can see these hemorrhagic pieces of tissue, so lots of hemorrhage. And there was maybe some necrosis present. And this is probably tumorous tissue. Here and yeah, this is better. This big epithelioid-like tumor cells with voluminous eosinophilic cytoplasm and vesicular nuclei, prominent nucleoli. And there was one important information on the requisition form which we usually don't have. The information is that the patient is diagnosed with tuberous sclerosis complex, right? So this is quite important information, and I would thought about the diagnosis, but it's nice to have it Okay, so probably some of you already know the diagnosis, right? So this is GFAP staining, so tumor cells stained for GFAP. And this is another quite important immunostaining. This is quite new antibody, at least in our lab, and it's called GPNMB, glycoprotein non-metastatic melanoma B protein, which is positive in subependymal giant cell astrocytoma. And this antibody is quite useful in diagnosis tumors having either TSC1 or TSC2 genes mutations or other alterations in mTOR pathway. And it's also useful in diagnosing tumors having TFE genes, rearrangements, including pecomas and some kidney tumors. So we have a paper, it's currently in press in Virchow's archives, where you can look on our results. We have stained for 10 or 12 SEGA cases, and all of them are having this diffuse and strong GPNMB expression compared to other tumor types, including glioblastomas and gemistocytic astrocytomas, which are mostly negative or have only patchy positivity in less than 50% of cells. But we also had some tumors having this diffuse positivity, so the context is quite important. Importantly, these tumors tend to have TTF1 positivity, which was described as probably the best diagnostic marker of SEGA. But in our series of cases, GPNMB showed better sensitivity compared to TTF1, and in fact, in this case, there was no TTF1 positivity, so I find it quite useful, this GPNMB antibody. So subependymal giant cell astrocytoma in a patient with tuberous sclerosis complex. And maybe I have time for very short another case. This was sent for methylation profiling. It's, I believe, posterior fossa tumor, and just like looking at this very low magnification, I can tell it's yeah, maybe it's resembling schwannoma, but
I don't know the differential here.
yeah, it's intraparenchymal tumor, so it's in the brain parenchyma, and it looks ependymal. So in low magnification, when you see something like this, it's almost always ependymoma or somehow ependymally differentiated tumor. And in this case, the cellularity is very, very low, and you see just like clustering of cells at some foci. So it's not like really like homogeneous tumor's mass, and the diagnosis on H&E is subependymoma, which is grade 1 tumor. And it came back with methylation profiling as subependymoma. Sometimes these cells may show like the degenerative, almost like ancient schwannoma-like atypia. Sometimes there are microcysts present, sometimes there are microcalcifications, which helps in the diagnosis. I believe calcifications were present focally in this case. So this is subependymoma. Importantly, if you perform methylation profiling, sometimes the CNS classifier will not be able to give you like definitive diagnosis, because some tumors histologically diagnosed as subependymoma will come back as ependymoma, and vice versa. Ependymomas will come back as subependymoma. So sometimes it's not really helpful for ependymal tumors, but in fact it doesn't matter that much if it looks like this. a really low-grade hypocellular lesion, even if it came back as ependymoma, I would diagnose that as subependymoma. Subependymoma is grade 1, whereas ependymomas are grade 2, more aggressive tumors. So that's it for today, and thank you for watching and listening.